Welcome to everybody who's just joining. We are recording the session, and the session is published on our website. So if you would prefer not to be on video, then please pop your camera off. It's a very informal meeting, so please use the chat facility or use the hands up facility. I think we are expecting quite a few people today. So what I'm going to say is we won't go around the room and do introductions. But if you're able to, if you put your hand up or if you speak, can you say who you are and where you come from? And if you are able to say who you are in the chat facility and the role that you do, that would be absolutely fantastic. But it's very informal, so please do join in with the communications or the conversations. Fantastic. Thank you, everyone. Thank you for joining us. We will be recording the meeting and it will be published on the Vivaldi Social Care website for openness and transparency. So if you prefer not to be on camera or not to speak, please just pop yourself off camera if possible. We're not going to do introductions. If you've just joined us, if you could pop who you are in the chat facility and the role that you do, that would be fantastic. Sonia's received some apologies for the meetings, but again, we'll pop those in the action points and the notes from today. Sonia, have we got any matters arising that have come up before the meeting at all, or are there any matters arising from anybody on the call?
Not from my end, no.
No. And no hands up. Fantastic. An action point, Sonia.
So everybody should have received the action points with the agenda. Has anybody got, rather than go, there's quite a lot on there, so rather than go through them all, if anybody has any queries now, please do pop your hands up and we can answer questions.
Fantastic. I think a lot of the action points will most really cover throughout the meeting today, and a lot of them are ongoing. So, but if outside of the meeting anybody has any questions, then please do let us know. Thank you.
Great. Bye.
Di's on. Hiya.
Hi, sorry, I couldn't find the link as ever.
Don't worry. Can I hand over to Laura, please, Professor Shawcross, to give us an update on the project overall? Thanks, Laura.
Hi, everyone. Great to see everybody. Good morning. We are almost getting to the point where we can start flowing data, which is really, really exciting. It feels like it's taken forever. So thanks to everybody for your patience and sticking with us. So where we've got to is we've got two sets of challenges to make this happen. One is a governance challenge, one is a technical challenge. The governance challenges we've been working through for about a year now, starting with our application to the Confidentiality Advisory Group. We got that approval last December. And since then, we've been working with NHS England to work through all the other processes around data. But the good news is we've got one more big meeting to get through on the 20th of November. And hopefully after that, we are signed off and allowed to start flowing data. So that's one thing that feels like it's almost there now. And then the second part of this is the technical part, which is where the data sits and where the data platform is hosted. And again, that's work that we've been doing with NHS England. And this has been delayed because of the change of government, because there are all sorts of decisions about where shared data should sit in the future, who has access and all this kind of thing. Long story short, we think we are almost there with a decision. And once that's been made, we're then going to be in a position to start bringing data in from the care providers. So Mike, you can pull a face at me if I've got this wrong, but I think we're aiming for January, beginning of January, to start flowing data. And then we're off, and then all the exciting stuff can start happening. So yeah, that's it from me, I think, Zoe.
Fantastic. Thanks, Laura. And Mike, if I can come across to you for a bit of a project update on training, on numbers. Before we come across to you, Francesco's got his hand up. Francesco, do you want to come in? Is it in relation to Laura's update?
Thank you. Francesca Santino Palmer, public contributor. It's just to know that the identity of both the data controller and the data processor, are they one of the same, or Outstanding Society one end and who's the other one at the other end? Thank you. That's all it is.
Yeah, so we've got 3 data controllers, so joint data controller arrangement. We've deliberately set it up like that. So it's us at UCL, Care England and the Outstanding Society. So that's enabling us to bring together expertise around the use of patient data, along with expertise around the care sector, to think about how the data sets can be used and so forth. And then our data processors are NHS England. So they're the ones where that's the environment in which all the data processing is taking place. And we're employing one software engineer from a company called Quantain Limited, who is going to work with the NHSE software engineers in the NHSE environment to set up our data pipelines. And we're working with him. Could somebody mute themselves? I don't know who's got the background noise. Thank you. And he's somebody who worked on the original Vivaldi study, and so is very well known to the team. So that's it really on controllers and processors.
Just to add a supplementary question, given that you've had approval for the past year and going forward, one of the considerations to be taken for getting approval from the confidentiality advisory group is that if there's anyone that could be affected by it, then should they be pointed towards a national opt-out, or is this secondary data that you're pulling and that is it and no further data?
Yes.
Yep. Okay, thank you.
Yeah. So we apply the national data opt-out, and we also apply project specific opt-out.
Thanks, Laura. Thank you, Francesco. Mike, coming back across to you for a general update, please. Thank you.
Yeah, general update on training is going well. We've hosted a couple of specific training sessions now for some bigger organisations. We've taken some days out to be able to just do those specific organisations because they wanted to invite their whole teams to them, so we fitted in with them around 2 specific training dates. We're still running the monthly training sessions, and last look on Eventbrite from me was that we had 90 signed up to the next one in November, which is next week. So training is going really well. We're starting to get a lot of more interest from the sector now in the training because we're getting so close to data collection. There's been no rejigs to the training format as yet. Working with Elisa to work out the questions we need to ask people around training as to whether it's providing the right information for them, and we're doing that as part of a setup through our new interaction system that we're currently setting up with Lucy, who I won't throw in the spotlight at the moment, but yeah, we've got a new member of the team, Lucy, who's going to be helping to sort that bit out as well. So yeah, that's all kind of progressing nicely, I think.
Fantastic. Thanks, Mike. And the care home numbers are still looking really good, approximately 600, and we're still getting inquiries in all the time, which is amazing. And more ICBs, local authorities, are making inquiries as to how they can onboard more care homes in their area. So in terms of the overarching project, everything is going incredibly well. And yes, as Mike said, a huge hello to Lucy, who is now full-time coordinating Vivaldi Social Care for us. So Laura, I'm just going to ask you to just spend a couple of minutes maybe introducing the dashboards before we hand over to UKHSA to lead on the conversation going forward. Is that okay?
Yeah, that's fine. Yeah. So just to remind everybody, so we've got 2 main outputs from this project, or from the first version of this project. So the first is dashboards. And so the idea here is that we use the data to measure useful things for care providers, for residents and families, and for providers. So we want to show the information in a way that is useful for people. And we also want to make sure that we're picking the top 10 things, or roughly 10 things, that are most useful and relevant for each of those groups. And so we've had quite a lot of work ongoing to think what those things should be. And we're going to start by measuring things like how many, the age of people in care homes, how often they go into hospital, those sort of things that give us a better understanding of the care home population. That's the first thing we're going to do. And then alongside that, we're going to start trying to measure some simple things about infections. So this might be, how many antibiotics do people in care homes get? How does that vary across care homes? How often do residents go into hospital for urinary tract infections, for example? So those kinds of measures to try and provide information on what is going on in different care homes to help those care homes improve the quality of care for their residents. And so UKHSA are going to give us a presentation on where we've got to in those discussions. And this is very much an iterative process. I think it's important to say we want you to bear with us here, because this is hard. We're not going to get it right first time. And so we need to work together to make sure that we're showing this in the most useful way. But we've got to start somewhere. So everybody be gentle, but we really want your thoughts and ideas.
Fantastic. Thanks, Laura. And I'm just looking, have we got... Yes.
Deji.
Thank you, Deji.
Yes. Is it okay if I share my screen?
Of course it is.
Of course it is. So hi everyone, my name's Deji. I'm a business analyst working on the UK HSA dashboard team. Just as Laura's kind of introduced what we're looking to do. So I met with Laura and a few stakeholders a couple of weeks ago, and we kind of captured the initial requirements. Also, what's happening in the background is that Graham has been so kind to provide us with a list of matrix, which Laura's just kind of alluded to right now. So we do have some setting matrix we'll be using to guide this data. But what you're looking at now is initially a very high level requirement that was captured. But out of those requirements, we had 4 or 5 outstanding ones which we needed inputs from the care homes from. So what I'll do now is I'll just read out these requirements to you, and I'll prompt you where we think we need the care homes information on. So the first one is, as a care home admin, staff or provider, I want a system that provides consistent and accurate data on infections and diseases so that I can monitor outbreaks effectively, ensure proper infection control, and maintain regulatory compliance. The question we've got here for you guys is that what type of data specifically would you be looking to see in this kind of requirement? And that's an open question. You can raise your hands up or go ahead and answer the question.
Does anybody want to? Francesco.
What was that Riviera?
I mean, elsewhere, I think Laura indicated what some of those, I don't know if you use the term,
Yeah, the matrix.
I would be looking at convenient sampling, because what you've actually got in terms of stakeholder is not just a care home provider themselves. If you actually looked at another way, looking at consensus with all the stakeholders, with similar to the James Lind Alliance for any condition, you'll probably see that most people are in agreement that things around intervention and treatments, improving quality of life, would be probably up there in the top 3. So I think convenient sampling, and I guess the narrative and perspective of each stakeholder will actually look different. From the, let's say NHS England, they'd be looking at rehospitalisation within 30 days, let's say, and mortality. And for those that don't meet, average life, with premature mortality being death, dying before the age of 75. If I've got that wrong, my apologies, but I'd be looking at convenient sampling. But we need to hear everyone's voices. It can't just be about the provider and the staff that work for those providers. Is that okay?
Okay.
Thank you.
Brilliant. Thank you. Laura?
Yeah, just to kind of to agree with you, Francesco, in that we definitely want to have quality of life measures. We definitely recognise that. For this first version, we're restricted to what's in the data, and so that is largely healthcare outcomes. But alongside this, we are working with other projects to see how we can pull in data on quality of life outcomes. So here it's really thinking about, of the things that we can measure because they're in the data, what is most useful, and how does this align with the requirements of the different stakeholder groups? And so that's providers, but that's also thinking about some of these other groups that you've mentioned too.
If I can just come in briefly there as well. So for the next Adult Social Care Engagement Collective meeting, we're opening it up to all partners, stakeholders, residents, relatives, team members, to provide an update. And Daisy's going to be coming and speaking to that group as well. So as Laura just said, we are opening up to a wider audience as well. Thanks, Laura. Karen, I'll come across to you, please.
Thanks. Obviously, I didn't pose this question, but my interpretation of it from the environment that I work in would be around compliance and looking at lessons learned and the themes that are coming up. Maybe it's seasonal trends, to ensure that the homes are having the correct preparedness for staff and they're taking the right precautions, and that they can demonstrate that as part of their regulatory process. So, for example, you know, if we're looking at an outbreak of a particular infection, then they can, if they do get a monitoring visit or a CQC inspection, then they can say, you know, we've had this feedback as a result of Vivaldi, and therefore these are the measures that we've put in place to accommodate that. That's how I would interpret that.
Brilliant. Thank you very much. Thank you. I'll go to the next one we need your input on, is number 6 here. So as a care home admin, staff, or provider, I want a system that can compare my care home's data, infection data with a group of comparable care homes, i.e. dementia specific, so that I can access performance against national trends and identify areas for improvements in infection control. For this requirement, so what kind of specific data would you be looking in capturing, or would like to see as a care home provider?
Francesco, did you want to come in there?
I'm not too sure you answered the question. I mean, if you go on public health website, Fingertips and that, you can compare local authorities against things like suicide and self-harm and other benchmarking outcomes and that. And, you know, they provide, you know, variations between those that have, unfortunately, more people that die by suicide and what the average is across all the local authority. But is there such a system in place where you can look at, you know, whatever it is, mode, mean, meridian of whatever it is that you're looking for between care homes of a particular size with a particular function that's either a standalone residential home or nursing home or dual registered? Does that actually exist as we speak? Okay, thank you. I think that was the difficulty with what you read out just now. I've not come across it, but maybe I've not looked at the right places. Thank you.
Okay.
Shall I come back across to you there, Daisy, in terms of what's already out there?
No, so what this is aspirational. So this is what we're looking to, information we're looking to capture. As you've rightly said, this information, part of it is available on Fingertips, is already readily available. I mean, the question here is that out of the data that just what Laura said, is that the data that currently available, what type of data would you like to see going forward? So is it something are there specific data sets you would like to see to compare? Or is there nothing you're happy with how it is at the moment?
So Laura, can I ask you to come in again and give some practical examples for everybody on the call? So what could potentially be seen from a practical point of view?
Yeah, so the kinds of data that we've got access to here are data on deaths and cause of death, data on vaccinations, data on hospital admissions, reasons for hospital admissions, data on antibiotic prescriptions, and hopefully data on infections, so the diagnosis, laboratory diagnosis, so things like who's got a bacterial infection and which kinds of bacterial infections. So we can't, there are lots of things that we can't measure yet that we hope to measure in future. But as Deji was saying, we're trying to use this data in the most meaningful way. And so an example would be, we know that antibiotic use is really important in care homes because of resistance to antibiotics. And so we could measure rates of antibiotic use in different care homes. But to do that, we need to compare care homes in a meaningful way. And so we need to think about things like how many people are in the care home, what kinds of people are in the care home, or, you know, is there a reason why some care homes have many more antibiotics than others because their patients, their residents are sicker, for example. And so it's trying to think about how we can present that data in a way that makes sense and isn't misleading.
Thanks, Laura. I think that explained that really well. Darren, did you want to come in there?
Yes, and actually it does build on a piece of work really which does exist in care homes already, because each care home is required by regulation to publish an infection control statement once a year where they have to report a number of infections, but that is a complete manual process. If I wanted to, I could now compare one of my homes to another home in the area, but I'd have to look at their infection control statement, which is an onerous piece of work. Whereas actually having a data set in a table form, whatever it is much easier. And if we're already required by law, by regulation, whatever, to do so, this will only build upon that and make it easier. So that for me is that the process actually already exists. What we're doing is building on it and actually making it easier for the providers themselves to get the data, because Vivaldi are doing it. So it's going to help build that and actually compare them to each other. The only thing I would say is, I don't know whether it comes up elsewhere, but it's not just national, but I would say regional trends as well, which I think we've said about earlier. So yes, national is important, but what applies in London is not going to be the same which applies in the Northwest, as an example.
And I think that's a really good example of things that we're looking at, Darren. And as it says in the chart, dementia specific. Do we look at homes that have 100 beds, homes that have 24 beds? Their information, their data is going to be very, very different. Nurses versus residential. So exploring that. So thanks, Darren, for those comments. Diane.
Actually, I think Laura's answered my question now, so apologies, I didn't know how to take my hand down. But no, I was just thinking about vaccines and how, when you've had a vaccine, it can very often cause symptoms of what you're having the vaccine for example, flu, and whether that's going to be kind of measured versus when they've had the vaccine and when the infection transpires. Does that make sense? But it sounds like it will be, so.
Yeah, Diane, that makes total sense. So that's exactly what we did in the original Vivaldi study, was so looking at of those people who hadn't been vaccinated, who then got infections against COVID, who got COVID. So how well were the vaccines protecting people against COVID? So we would really like to keep doing that kind of work, but also do it for things like flu and any other vaccines that come online in future. So yeah, absolutely, we'd like to do that kind of work. That is going to take a little bit more time probably. And it's more in the research space, but we could definitely look to put some of those things on the dashboard in a longer term.
Thank you. And just bringing it right the way back down to basics again, a lot of the information that we've got, we just don't know who out of the population is living in care homes, and that's what Vivaldi Social Care is actually giving us, which I think is really key to revisit again. Deji, can I come back across to you again, please?
Sure. So the next one down is, as a care home admin or data team, I want to be able to export in CSV and Excel from the dashboard so that I can tailor the reports to individual needs. So this requirement here is talking about just generating reports for the care homes. The question we have is that what data can be shared with whom? So do you want a report whereby anyone within the care home can see the report? And also, do we want care home providers to see individual data against each other? So do you want care home A to be able to see data from care home B, or is it something that's that's not acceptable?
Leanne.
Hiya. Yeah, I think that would be really useful for us to compare because we are national. So again, when it comes back to the regional comparison, I suppose looking at perhaps the services that are available in those areas, the quality of services, the engagement time with services, how long are we waiting for antibiotics, things like that. That would definitely be useful for us.
Okay, thank you.
Thank you for that. And Francesco?
Not sure, but elsewhere, when you look at national clinical audits which are undertaken by NHS benchmarking, with early intervention psychosis, they don't like to identify mental health trusts that are not somewhere near the average and they're not performing well. So they usually give them a reference number. There's 54 mental health trusts, so it could be 1 to 54, but not identify which is the underperforming trust. Now, would it be the case that you can do it across, identify it within a locality of a integrated care board, or is it that you need to name each and every care home? Deju, that's the question that you're asking, isn't it?
Yeah.
Would mention was made earlier on, about trustworthiness, transparency. So in that respect, is that something for the public domain then, all this data, so that people, carers, family members, people with power of it?
Yeah.
Yep. Okay. Okay. Thank you.
Okay, thank you. The next one I've got is the reporting requirements as well. So as a care home admin, staff, or provider, I want to be able to download a reporting PDF from the dashboard so I can send a non-editable version to the users, i.e. care home residents. What type of data do you want care home residents to see? Just like what we've been discussing earlier, do you want them to be able to see all the information, or do you want the information to be masked or encrypted in certain ways?
Leanne, first of all, please.
Sorry, me again. I think it's really important for us to be really open and transparent, because I think that's the reason that we're getting involved in this study. And that's like going back to the previous question, especially with staff, we have governance boards, so we share that quite widely per service, so people can see each period on period how that works. For us, I would say the way that is presented, for especially for residents, we may have to look at that, breaking that down a little bit more internally. So we do a lot of easy read versions of things. So whether we do that pictorially or, however that might look, but that is certainly something that we would be happy to look at to share that in the most appropriate way.
Brilliant. Thank you very much. Okay.
Thank you.
Thank you.
Thank you, Anne. And Diane?
I think Leanne's just hit the nail on the head. It's going to be about translating it in a format that people will understand and even want to know about, really. And I think, when we're talking about care home residents, we need to think about the relatives as well. So not just the residents, but their families, because as we know, a lot of people in care homes don't have capacity. Some people will want to know, some people won't. But I think the families of residents will be equally as key in understanding the data and whether or not they want to know the outcomes of what we're measuring.
Thank you.
I think that's a really valid point. And Deji, just so that we can understand, so once it's been decided on the data that can be pulled off of the dashboard, could things like easy reads and the way that it's presented be changed as we go along? It's mainly we need to know what data needs to be downloaded. So could the
Exact-
format at a different stage?
Yeah, exactly that. So before we develop anything, we'll have to consult you to kind of agree with templates that would be acceptable for everyone to see. So yes.
Fantastic. Thanks for clarifying. Darren, do you want to come in there, please?
Yeah, so this might be a completely null question and not valid at all, but I'm just thinking when we're collecting the data in terms of it, is there a minimum level of people to be included before the data report is published? Does that make sense? So it has to be, a minimum of 5 people, minimum 10 per location, just because then the worry would be that if it was too low, then people technically would be identifiable.
So I don't think we've got a minimum level. We've come across that. So no is the answer to the question. I don't think there's a minimum.
Yes will be the answer to that question, I think, Deji. Okay. So in terms of us extracting the data from NHS England, then because we're using care home level data, they want us to apply small number suppression. So yes, we will. We haven't agreed yet whether it's 5 or 10 or what those numbers are, but we are going to adhere to that principle of small number suppression. Yeah.
Okay, cool. Yeah.
Suppression. Okay.
Thanks, Laura.
And the final one is, as a care home admin, staff or provider, I want a mechanism where for the dashboard to feed back to the care home so that I can compare data and identify opportunities for prevention and care. The question we have here is that which data the care home residents want to see. So as a feedback mechanism, what type of data is kind of valuable to the care homes to kind of basically create a feedback on?
Francesco.
Yeah, I would have thought, in all fairness, I know that the regime with the Care Quality Commission is changing to a single regulatory assessment process, but the domains of SAFE is still going to be with us along with effectiveness and caring. I would have thought, if a resident is in a home that's got a rating of require improvement, it wouldn't be unreasonable to ask, regarding the government, what steps are being taken to move from such a rating to one of good, so that they can, know that if it was a question of being a provider of choice, it wasn't just a question that they were just dumped into a home which otherwise wasn't rated as good. So there needs to be, quality assurance or improvement along the way, and see how family carers, to a lesser extent maybe, can be involved in that process. Okay, thanks.
Thank you.
Thank you, Diana.
Sorry, I am going to button everyone out, but I can't help it. I just think that in terms of, and I might have this completely wrong, but I'm even thinking about myself, and if I was in a care home, what data would I want to see? And to be honest, the only thing that I would want to know is, how does it affect me? What is the outcome of that data that is going to improve my life? That is it in a nutshell. And I think, I don't think we need to dig down too deep. I think they just want to know, in my opinion, I think they'll just want to know, what difference is this data going to make for the quality of my life? That's just my opinion.
Thank you very much.
I think that's a great point. Thanks, Diane. Francesco, did you want to come back in there?
Yeah. It's just a thought. In all fairness, if you undertake, if you look at the Equality Act 2010 and look at the 9 protected characteristics across all the residents in the home, there may well be those that lack capacity. So as such, they've got significant others that have got power of attorney or deputyship, where capacity was lost before consent was given. People whose first language isn't English, so how do you translate that information that you're talking about to people whose first language isn't English? Those that may have other issues. So I would have thought that a quality impact assessment across the home and across the residence would need to be taken so that it's somehow able to ensure no one is actually left behind. Thank you.
Thank you.
Thank you, Francesco. And I think that I'd be assured that care homes would have their internal processes for that as well. Leanne, do you want to come in there?
Yes, sorry, it was just that was what my point was about, really. It was about our own internal processes. So in the wider context for our families and our service users, we may feel like our governance and quality assurance processes are effective, but actually it'd be really helpful if your data is coming in and saying something different. And our IPC audits, for example, are saying, oh, we're at 98%, but we've got a really high rate of infection, then there's something that isn't working and correlating there. So I think that would be really helpful for us as well.
I think that's, again, a really valid point. Thanks, Leanne. Darren.
So yeah, I think it's just building on Diane's. I think data maybe is the wrong word to use. I think the data is for the care home to use, and then it's what the care home does with the data, which then presents it to the people that lives there. So I think, which data do care home residents want to see? Probably none. They'll probably want to see it's that question of, so what? So what does the data mean? So what if this care home done differently? So what's happened in this area as a result of the data? So what does that mean to me as an individual? Will I be able to access this service now as a result? I don't know. That there could be a million questions that come out of it, but I think it's the presentation of the initiatives rather than the data itself. Yeah, and then I think obviously then that builds into them being involved and will eventually lead on to the quality statements if we ever get there, with CQC and people be involved in their care.
Brilliant. Thank you very much.
I think again another excellent point, and I think it's about having the levels of information, so people, if they want more information, they can find it, so it would be there available. But actually, if they want it in a different format, then that's available. So I think that's a really good point. Thanks, Darren. Laura, do you want to come back in?
Yeah, just to come back in on Darren's point, I love that. It's great. So this is like a whole other area of activity. We need a toolkit or something, don't we, to say, okay, so now we've got the data. How do we go from, we're giving you this data, how do we help you think about what you might do on the basis of that data to change things, improve things? How do we make those connections? So that feels to me like another area of activity that we need to think about alongside this. But yeah, really important, really exciting. Thank you.
Thank you. And I think this is maybe one of the reasons why we're having the discussion about actually, going forward, the Adult Social Care Engagement Collective, what's its purpose, what's its function, and do we need to revisit the members sitting around the table to have more voices? So yeah, thanks so much. Deji, back across to you, please.
No, so that's pretty much it from me. Thanks for all the inputs you've given. I've written it all down. I would all incorporate it into these requirements, and we'll carry on with the next step. I'll be feeding back to Laura, and she could pass the information across to everyone. So thank you very much, guys. If there's any more questions, please let me know.
Do you mind just letting us know? I know we've got the meeting in December that I briefly mentioned, but what are the next steps from your point of view, please, Deji, in gathering more information?
Ruth, do you want me to go ahead, or do you want to give a very more high level? Because I'm the business analyst on the team, so my next step is pretty much capturing the requirements, passing it on to the dev team. We'll have a look, do further analysis, then we'll be able to come back to you with like an MVP, which is like a minimum viable product, saying this, the initial first deployments and on the dashboard, this is what it will look like. So that's the next step. On a more strategic level, is there anything else you'd like to add, Ruth?
No, I think you've covered it off. Hi, sorry, I'm Ruth Baxter. I'm the product manager within UKHSA. Yes, so we'll take these requirements back to our team. We will discuss the requirements with our team, understand feasibility, and come back to you with a prospective kind of first iteration of what we can and can't do after kind of understanding the feasibility side of things. So that would be our kind of next steps, and we're in continuous kind of communication with Graham, who's on the call as well, but that would be our next step. So we'll be feeding back to you hopefully pretty soon.
Fantastic, thank you. And I know Graham's in all of these meetings, but if we could possibly put it as a standing agenda item on this group who meet monthly, I think that would be really valuable. If that's okay, if Graham or a colleague could feedback every time, that would be really beneficial. Lovely. Excellent. Thank you very much, Deji and Ruth, for
Thanks,
coming in.
everyone.
Many
Thank you.
thanks.
Thank you.
Excellent.
Thanks, Di. Bye-bye.
Lovely. Wonderful. So moving on then, if there are no further questions on the dashboards, terms of reference and membership review. We have sent the terms of reference and membership out again ahead of the meeting, and I wonder if anybody's had any thoughts on if there's anything that we need to review in more detail. It might be that the major responsibilities of the Adult Social Care Engagement Collective are covered already by the three main points. So just as a reminder to everybody, by facilitating feedback from providers to the trial team on the level of opt-outs, documentation, training, and other feedback from residents, relatives, and team members. Second point, by ensuring that Adult Social Care Engagement Collectives' views are represented at the Vivaldi Stakeholder Oversight and Governance Group. And thirdly, by ensuring that the Adult Social Care Engagement Collective views are represented at meetings of the Vivaldi Data Access Committee. So they were the broad outlines of roles and responsibilities. And obviously our agenda is going to be changing throughout. But has anybody got any thoughts, any feedback on if anything needs to change within the terms of reference, or is that broad enough to be able to feed into the different groups within the Vivaldi social care study? And moving on to membership, in terms of membership, has anybody had any thoughts around how many providers, how many residents, relatives should be involved in these monthly meetings? Again, we said at the last meeting, we tend to have about a 50% attendance rate at these meetings. We've actually got, let's have a look, it's 40 registered members within this group. Has anybody got any thoughts on Diane? Do come in.
Just one thing that did cross my mind. I know you're looking at people with lived experience, but I don't know how to say this without. But for example, I think I've got lived experience because I've lost someone who lived in a care home. But are you looking for people who have still got that person in a care home, or are you happy to have people who are not? Do you know what I mean? Who have actually lost someone but have an interest in what happens in care homes because of their experience?
Yeah, I would say we would absolutely be looking at people from both points of view. I think both would be incredibly valuable, and it would be crucial, I think, to have people with relatives living in care homes or people living in care homes themselves within this group. So if we could reach out via Rights for Residents, maybe going forward, to see if anybody was interested in joining. And I think also there's an element of a pool of people as well. So if somebody can't make every single monthly meeting, could we have a bigger pool of people who have got experience that could join the group? That would be great. Thank you, Diane. Francesco.
So I've got.
Yeah, just to say, with my mental health trust and a couple of other providers, they look at more relevant current lived experience. So people that have either used their services or cared for someone that's used their services in the last 24 months. So I don't know, it may well be, you know, people have got different experiences regarding loved ones that are in care homes and that. So, you know, you may decide that, you know, you want a representation, because you're not, you know, the difficulty is that you're not likely to have actual care home residents that are part of this group or the governance group, unless you tell me otherwise. So the likelihood is that it's those that have got, you know, family, friends or others in such care homes that are providing support, and either as unpaid carers or those with lasting power of attorney or deputyship, or are they just friends? It's for you guys to determine the level of knowledge, expertise going forward in terms of the membership. Thank you.
Thank and I think that is a bit of a moving membership, and also it's about who feeds into this group, because we do very heavily involve residents in these conversations as well. So we have our monthly care home visits, where the whole team meet with residents, which we can move on to, and hopefully Kate can give some more feedback again in a minute from our recent care home visits. So I think we do feed in from residents, but in different ways, and it's about adapting to that. So maybe we need to, in some ways, adapt the terms of reference to make sure that is reflected, that the views of residents are also included within these discussions as well. Thank you, Francesco. Leanne?
Sorry, just to clarify, I kind of missed part of that then. So do we have a forum like this where residents can come on and give their views? Is that this forum, or would that be a different one?
It could absolutely be this forum. We would absolutely welcome residents.
Yeah.
And we also say, I don't know whether Mike wants to come in, but we also say about our drop-in sessions, the meeting that's taken place in December, we're encouraging providers to invite residents and relatives along. Mike, do you want to come in there?
Oh, sorry.
No, I just just want to reiterate that what you've said there. Like we say at the end of every training session, the drop-in sessions are for residents, relatives, anyone that's got any questions or feedback for the study. We want to hear from them rather than anyone else. So we kind of collate all of that information into one place. But this is a perfect place if they want to actually be sort of involved. That's a more kind of informal way of being involved. You know, kind of just that they just talk to us about it, but if they wanted to be physically involved in this, that would be superb, absolutely brilliant.
Yeah, we so are you happy, because we have councils and ambassadors that represent through council the wider population, so you're happy for us to just share the links with them to get, yeah, okay, fab, thank you.
And everyone out there doing that as well, that would be great.
And I think maybe that's an action that we need to take away from today. Thank you for bringing that up, Leanne, because we obviously don't make it clear enough that residents can join this group. So Mike will go away and we'll make sure it's communicated out again to providers, and maybe we'll revamp this membership from reoffering that opportunity to residents again. Thank you for bringing that up, Francesco.
Just want to check if the home is part of the Vivaldi project. So it's you know, does it mean that each and every, unless there's been a resident that have gone to the national opt-out, that everyone's included? So would there be a conflict of interest if a resident in one of the homes that you undertake some of the study with was actually a member of this, you know, whichever group? Would they need to separate themselves so there wasn't a conflict? I don't know. I in terms of governance, I don't know the answer. I'm kind of like just thinking of the difficulties that potentially there could be, but just a thought. Thank you.
Laura, do come in.
Yeah, just to say, so it's the NHS opt-out. It's also a project specific opt-out. So they have two mechanisms to opt out of the study. I don't think it would be a conflict of interest because I think it's representing views and advice. So I don't think that would be problematic personally.
I would tend to agree, Laura. Thank you.
Sorry,
so-
Mike, I put Mike's hand down because I was lowering Laura's hand.
It's quite all right. I was going to kind of just sort of say what Laura said. I don't think they have the potential to influence the study data or that. So I don't think there's a conflict. We'll have a think about it though.
Can I just say, in that case, none of them, if they come in this group, are participants at any stage. Thank you.
Laura, can you just clarify that point, because they would be participants?
Sorry, so what's the question? So if they would be submitting their data.
Sorry,
Okay.
if you've got a 50-bedded care home that's part of the Vivaldi
Yeah.
project, then the assumption is that whatever data is collected, everyone's in, all 50, unless, I presume, let's say somebody that wanted to join this group went to the national opt-out and they opt out. So you can't be a PPI representative and a participant. It just can't happen. So that's the bit I'm kind of like just thinking about, confused. I know that some of the other studies that I'm involved with, I'd love to be a participant, but I'm actually a co-applicant. Because I feel that a lot of good could come from it, but I can't do both roles. So I'm just curious.
Yeah, I think though, because the role is it's passive data collection, they're not actively participating. I don't see how that would be a conflict. And when we're looking to collect data on around 45,000 people, so it's a large number of people. I think it would be a shame to exclude people in participating care homes, because they're going to have insights that people who are in homes that aren't participating won't have.
No, I'm kind of like just thinking, normally with participation, there's usually a patient information sheet and a discussion about valid informed consent, about being involved in that. And if that process hasn't occurred, somehow they're not participants, but are they, regardless of that process not occurring? Thank you.
Yeah, I think it's a bit different when you've got, say, clinical trials where you've got informed consent and all of those kind of things. But because we have this opt-out consent model, and because it's passive data collection, I think that this is okay. And it's so important for us to get the views of people in homes that are participating.
Totally agree. Thank you.
Thank you. So moving on, I'm aware of the time. I wonder if Kate could give us a bit of feedback on the recent care home visit, if that's okay, and how we interact with residents, relatives, stakeholders.
Sure, yeah. So last week, a big group of us went up to Telford, and just, for the record, to say thank you to Sam and all the team at the Maples for making us all feel so welcome. It was great. There were a lot of residents and families there who listened to the presentation and listened to what Vivaldi was all about. And actually, it's sort of before the presentation starts, really, is a great time, because I certainly am able to go up and sort of sit and chat to the residents and talk to them on a more personal level about what it's all about, find out what they think of it, gather their views and whatever. We were lucky enough to also have Lucy Chappell with us, who's the Chief Scientific Advisor to the government. So it was great to have her input on the research and how important it is. And it was a really, really good visit. But yeah, as you said, there were a lot of families and residents there at that one. So it was great to have their input and for them to be able to ask questions as well of the teams. And it's not just about the hour, it's about the sort of 3 hours that we're there, sort of before and after as well, being able to sit and have a chat with them all. And certainly that across most of the visits we've done has been the case. So it's being able to get that, speak to them on a more personal level. It was a good trip.
Thanks very much, Kate, and Laura and Mike. I don't know whether you want to come in just to maybe talk about the importance of having people like Lucy Chappell at these visits and other colleagues across the Department of Health and Social Care.
Yeah, I can start. I mean, it all depends on which kind of world you occupy. But in my world, in a kind of research world, people like Lucy are extremely important because she runs the National Institute for Health and Care Research. So this is our major one of our major research funders in the UK. Their budget's over £1 billion a year. And so it's just amazing that she was, you can imagine she's pretty busy, and that she came to one of our care home visits and was so enthusiastic about research in social care, so pleased to see what we were all doing, and so keen to see more of it. So it just shows the impact that our work is starting to have, and the opportunities that we've got to really shape the future of the research in this sector. So yeah, very exciting.
Thanks, Laura. And she was very keen to get people's views in the room around, what messages do we want Lucy to take back to the minister and their teams. So incredibly positive. Excellent. We've got a couple of minutes left. Are there any providers on the call who would like to come in and give a brief summary of how conversations are going with residents, team members, or any part of the project out there on the floor at all? Is there anybody that wants to feedback briefly? And if not, shall we move on to any other business? One of the main points is that our next meeting on the 10th of December is going to be at the same time, 11 till 12. After this meeting, we'll send out links to everybody and invite everybody that's part of the Adult Social Care Engagement Collective to the meeting that's taking place. And we'll also send you out the Eventbrite link, and please share it far and wide with everybody. It's open to everybody to have an open discussion about the project and where it's going from here, and potential dates for data collection. And also Deji will coming back to discuss the dashboards again. Darren, I saw your hand up. Did you want to come in there?
Yeah, no, that's okay. Thought I'd just give some feedback. I know the team at Bracebridge, you had a few people attend when you were at the Care Show in Birmingham, and they really enjoyed it. So the feedback was very positive. So thank you. And that's what I wanted to say, really, from a provider point of view, that it was well received. Taken back, refreshed all the certificates to make sure they're all looking shiny and brand new and not forgotten. So all good. Thank you.
Fantastic. Thanks, Darren. And we look forward to seeing the comms and photos that will be coming out shortly.
Yeah, definitely.
Lovely. Diane.
Actually, it was just something Darren said then that made me think, have we got any kind of, I don't know what the word is, like for care homes that are participating, have we got any kind of certificate to say, that they could put up in their care home to say, I am participating in the Vivaldi project? Or
yeah, so every care home signing up and participating has got a proud to participate certificate that we present on visits. And we were delighted when we arrived at the Maples last week. They had it right in their foyer, which was absolutely amazing. So it's really lovely.
You come to any Bracebridge home, I guarantee you, apart from the care home's name, it will be the first thing you see.
Amazing. Amazing. Yeah. Thank you. Lovely. Well, if there's no other business, thank you everybody for your time. And we look forward to seeing you in December. Thank you very much for your participation.
Thank you.
Thank you. See you soon.
Bye. Thanks, everyone.
Bye.
Bye.